good morning to everybody. Welcome back to Medical Grand Rounds. We did have a week break last week in honor of public school spring break in the area. So thanks for rejoining us today. I'm Dr. Laura Lacher, and I am here for the virtual version of our Medical Grand Rounds. We will try to keep you posted about when we are available in person, which does vary a bit week to week, but is always noted in the email invitation that you get for Medical Grand Rounds. And just a few reminders, this is a collaboration between Providence St. Vincent and Providence Portland, and you can earn CME credit by being with us here live virtual, or coming to a live event, or by watching a recording of the session, and that is available as the same link as the invite. I'll be keeping an eye on the Q&A throughout our session, so please go ahead and put in any comments or any questions that you have for our speaker, and I'll mostly hold those until the end to ask as time permits. Next week, we will be hearing from Dr. Sean Stanley, who will be discussing adult ADHD. And now to introduce today's speaker, we are joined by Dr. Nisha Patel, a family medicine physician and geriatrician practicing in the primary care division of the Center for Women's Health at OHSU. She trained at Jefferson Family Medicine in Philadelphia, Pennsylvania for residency and fellowship, and then went on to practice for 5 years working at an urban underserved hospital system in Camden, New Jersey, before moving to Portland in 2020. Dr. Patel has established a geriatrics consultation clinic and is the clinical lead for promoting age-friendly health systems within the center. We're so grateful for her generosity in joining us for some teaching today. Thanks, Dr. Patel.
Thank you. Thanks so much for the introduction. So today we're just going to jump right in and talk about my favorite patient population, which is the older adult. Hopefully the tenets that you take away from Deprescribing, you'll be able to apply it to your entire patient population that you see. But what I'm hoping today from this talk is that you are able to kind of think and use a lens of taking care of older adults, use a geriatrics lens, to how we think about the older adult. So, main takeaways. So I'm hoping to help you kind of develop that framework that I mentioned. Learning how to recognize patients who could be good candidates for actually reducing medication burden. And I think it would be very unrealistic for us to be able to go through, a myriad of medications. So we'll focus on which patients we should consider deprescribing in, and tools to help you do that safely. Stephanie, I think your mic is on. Sorry.
Is your mic on?
Sorry, I'm just hearing the mic. Thank you. Sorry. So I was just saying it would be unrealistic for us to kind of go through all of the medications. So we'll consider deprescribing in certain patients and what tools you're basically going to be able to use to help you do that safely. And then also identifying which of those medications are considered high risk. So the question that I get asked a lot is, how do we define an older adult? And so much of that depends on who it is that you are asking. So Medicare obviously gives us a definition of 65 and up. We, as many geriatricians, probably think more 80 and up as being the older adult, but we all know that we can have younger patients that are more medically complex, have a lot more comorbidities, and a lot of older patients that are healthier as well. So we think about an accumulation of comorbidities as really being the biggest risk of having an accumulation of medications. So with some literature review, on average, it sounds like about half of our patients probably take over 5 medications. And I'm sure as you all think about pulling up that EPIC medication list, there's a ton that are usually listed. And there's an increased risk of adverse drug reactions when we have more medications. So some numbers kind of pre-pandemic the vast majority of older adults who ended up in the emergency room were actually due to medication-related adverse events. So our goal with deprescribing is going to hopefully be able to prevent some of that. And our high-risk medications are definitely the most problematic in our most vulnerable older adults. So kind of thinking about those that are high falls risk, are considered frail, who may have advanced cognitive changes, or in those that have a high medication burden. And just thinking about, when patients have so many medications, even trying to remember when to take which one, even if you have a pill box. For example, I have patients that will say things like, but this one I have to take 30 minutes after eating, and then so I set a timer and that one's not in my pill box. It just becomes quite complicated. And what we don't want is for our patients' lives to kind of revolve around remembering when to take their medication. So deprescribing also in part is to really help simplify those things for our patients. So this is a great definition. This was published in the British Journal of Clinical Pharmacology, and I was amazed at the number of papers they looked at to come up with this definition of deprescribing. It was basically an entire study looking at what is the definition of deprescribing. So key tenets of it is that there is withdrawing of what is considered an inappropriate medication. It is supervised and not one that is just abruptly stopped. And the goal really is with deprescribing, managing polypharmacy and really improving patient outcomes. So, what are some of the outcomes that we look at and think about? So, one, as we talked about earlier, just decreasing that burden. The other big thing that I think about is often reducing medication costs for patients, helping to improve the medication adherence. So, if there's fewer medications that they need to think about taking, and they're really focused on what medications it is that they need to take, that can be really helpful in terms of making sure they're taking the medicines that they have. The other thing that I think is really helpful and what I find day to day with patient interactions in clinic is if we are able to really explain to a patient why maybe a medication is no longer needed, why we want to take the medication away, it really does help improve patient engagement. And we really are kind of empowering our patients in that sense. And they are having a better understanding of their medications and kind of advocate and say, perhaps I'm having these certain side effects, so maybe I should let my doctor know because these could be related to these medications. So helping them feel a little bit more in charge of their medications. Oftentimes, as well, with deprescribing, we're often deprescribing after an adverse drug event has happened. Ideally, when we're deprescribing, our goal is to prevent these adverse drug reactions from even happening. So, one of the ways when I start thinking about decreasing medication burden for a patient, this is the lens that I use. So I'm not sure how many folks have heard of age-friendly health systems. This is an initiative that is out of the John Hartford Foundation, and it is a part of IHI, which is the Institute for Healthcare Improvement. And they have this framework, both for inpatient and outpatient clinics, where you can become certified, which our clinic actually is certified, the Center for Women's Health, and actually all of our primary care clinics at OHSU, thanks in part to a lot of hard work done by a handful of our geriatricians at the clinic. So what we want to do is have our clinics align with these 4 pillars. And I think this is such a great framework for us to just think about our patients within each clinical setting. So one thinking about what matters to the patient. So making sure that we're thinking about their goals of care, not just with end of life goals of care, but what is their day-to-day, what matters to them? What is it that they want to be able to do? And kind of across all care settings, right? From their life outside, at home, day to day, if they were to end up in the hospital, what types of things are important to them? And kind of keeping in mind those preferences that they have. Mobility is the next one. We're going to go counterclockwise. Really to making sure that we're doing everything we can to help our patients move about safely every day to be able to do what matters to them. Next is mentation, really preventing, identifying, and treating things like dementia, depression, delirium across all of the care settings. This is probably the one that varies a little bit more. So inpatient age-friendly health systems is really focused on delirium prevention, whereas outpatient is more focused on making sure you're screening and treating dementia and depression. And all of this comes back, I think, to medications, making sure that when we're prescribing medications, there are those that are absolutely medically necessary and medicines that don't interfere with the other three pillars. So medications that don't affect their ability to do what matters to them in their day-to-day lives. Medicine that doesn't impair mobility, so medicines that don't increase fall risk, ideally. And then medications that don't affect their cognition. So this is a great set of things to look at when you're also starting to look at medication burden for patients. So as we go through and talk about the different things to look at and talk about examples, I'm sure many of you will be thinking about certain patients of yours, and things will come to mind about medications. Perhaps you've tried deprescribing and have found it to be a bit of a challenge. So something to just kind of keep in the back of your mind as you're thinking of these patients is that older adults alone are a very vulnerable population. And unfortunately, in our healthcare system, both Black and Hispanic older adults definitely have proven poor health outcomes of any of their chronic medical conditions. And, we're kind of adding on all of the different layers that fall within that inequality, right? There's socioeconomic differences that really may affect a patient's ability to either pay for a medication, afford a medication, perhaps that impairs the choices of medications for what we prescribe. It definitely affects their access and adherence to medication. And typically in our most vulnerable, ethnically diverse older adults, medication adherence rates are much lower. So just kind of keeping that in mind as you think of your patients and as we move forward. So how do you decide when it is the right time to think about reducing medication burden? So one instance is if you are identifying a patient who has polypharmacy. So more medications we know mean that there are more interactions between medications, and in all of the research that's been done, for the majority of research purposes, they define it as greater than 5 medications. There's some that define it greater than 4. And I think it's important to remember that this is not just our prescription medications. We all have those patients that take all these additional supplements and different over-the-counter medications. I know I have been burned many times by forgetting to ask. And when I finally get down to the nitty-gritty and I'm asking questions, there's all of these sneaky Z medications. And what I mean by that is the Tylenol PMs, the Advil PMs, the Benadryl for sleep. Oh, I just take it to help me sleep a little bit better. And we all know how problematic Benadryl is in our older adult population. So really taking the time to think about all of these additional medications. The other common supplement that tends to have a lot of side effects is turmeric, which a lot of patients are taking pills to help with any like inflammatory process that's going on. So patients who have a lot of arthritis, this oftentimes will cause a lot of GI side effects. So really kind of keeping that in mind. So what are the opportunities if you're seeing a patient with polypharmacy that you might want to take time and think about deprescribing? So inpatient admissions, especially after a fall and resulting injury. So we're all great at, I think, identifying those really high risk medications, but also just thinking a little bit about the drug-drug interactions and what might be really increasing the risk of fall. When I was in fellowship training, we had this wonderful program at our hospital system where if any patient was admitted to the trauma service that was over the age of 80 and had a fall, the inpatient geriatrics team is always consulted. And our job was to actually do a really thorough medication reconciliation and try to figure out what some of the offending culprits are and try to make changes. That's in an ideal world. I know that we are not also lucky to have that in an inpatient setting. And oftentimes in primary care, that falls on us to kind of take a look at the medication list and think about what maybe they may or may not need. Transitions of care are also a great opportunity to think about just deprescribing. So I'm thinking of patients that go from inpatient to perhaps to SNF, or from SNF when they're leaving and they come and they see you in the outpatient clinic, really taking the opportunity to look at the list at that time and make sure that everything that's on the list makes sense and there's a real indication for it. Personally, what I find to be kind of just what works for me on a day-to-day basis are reviewing medication list at the annual Medicare wellness visits. And I find that a good time to kind of pause and just look at the medicines and make sure that they are all still needed. Another example I came across of how to deprescribe in one of the articles that I had read is the recommendation to just pick 1 or 2 patients a day in your clinic schedule where you're going to say, okay, this patient and this patient, I'm going to do a thorough medication review and think about how we can potentially reduce medication burden. And I think this can get very overwhelming if we have patients that have numerous medications that we want to take off. So I think be kind to yourself. Don't take it on to do all of them all at the same time. You really want to pick a specific medication that you want to start with deprescribing and slowly work your way through. And a lot of times with these routine clinic patients that come in, if anybody ever comes into me with a new symptom in my geriatric patient population, one of the questions I always ask in taking the history is, are there any new medications that were started, whether it was something that I've prescribed? So typically I think of, what did I do to you that made you have this symptom? And a lot of times it is what we give our medications and potential other interactions that are going on. And so one of the other issues that we often run into is this prescribing cascade. So the first thing that comes to mind when I think about this is opioids, right? If a patient is in the hospital, they leave the emergency room with a prescription for opioids for pain, and then they develop nausea. So we've got medication to treat nausea. They develop constipation. So we're adding on medications. And it is relatively easy as we're treating these adverse effects from the initial medication that we just start to layer on medicines to really treat the side effects. So really just taking a pause and saying, is this an initial medication still indicated or still needed? So polypharmacy is one way to think about deprescribing. The other one is frailty. I really love this definition of frailty, a clinically recognizable state of increased vulnerability resulting from decline in reserve and function across multiple physiologic systems. So these patients typically are the ones that we can identify in clinic to say, you know, this patient is really frail. They've had a lot of hospitalizations, kind of lose that ability to bounce back as well. And so typically the patients that you would imagine in your head, and I'm a very visual person with that, so I'll show you that on the next slide. An easy way of identifying frailty, if you're unsure, is having them do the timed up and go test, which I know a lot of clinics are doing if a patient is a risk for falling. We use it often for that, but this is very much correlated to the frailty of a patient as well. So if you do the timed up and go where you're having a patient get up from a chair, walk 9 yards, turn around, come back and sit back down, if it takes more than 20 seconds for them to do that, they are likely somebody who is considered frail. And I think important to remember that frailty is certainly not synonymous with age or multiple comorbidities. And as I said, I'm a very visual person, so I really love this clinical frailty scale, which has these images of our patients on the left. And I feel by and large, a lot of the patients that we start to see in the outpatient setting probably fall under this 4 and 5 range where they're vulnerable or mildly frail. And then as we take care of them over time, they can kind of progress through. So identifying when their needs are increasing and thinking that maybe, hey, we need to stop and pause and think about what medication changes we potentially need to make. So how do you decide which medication is the highest yield? And then how do you actually begin the process of deprescribing? So high-risk medications are always a good place to start. And our goal obviously is to ideally deprescribe, but realistically, I know that that is not always the case. Sometimes if we have the opportunity to change them to a safer alternative, or at least to a lower dosage if deprescribing entirely is not an option, especially if the patient has true symptoms that need treatment and discontinuing a medication is not really an option. So you'll see the list of medications on this slide, which I will say benzodiazepines are probably the biggest challenge in having people let go of their benzodiazepines that they've been on for 20 years to help them sleep, and they really feel like they need to continue it. And I just want to give a quick example of the actual why it matters to have that really thorough review of the medication list. So my first year out of training as an attending, new patient in her 70s that came in to me brought in her medication list, but she had 3 different medication lists from 3 different prescribers. And each one had a different benzodiazepine listed on it. And she was taking each of them. So the one that she was taking on a regular basis was from her prior either psychiatrist or primary, I don't remember, but she was on alprazolam 1 milligram 4 times a day. And then the other 2 were both prescribed by other providers as needed for nausea. And so, in this scenario, I had a little bit of a panic attack that thought about, okay, realistically, what are we going to be able to do? And the best that we were able to do for her was to take her off of the 2 PRNs and to get her 4 times a day alprazolam down to 3 times a day. So it's not always perfect, but we do the best that we can. The other medication that comes up a lot, I think, with the older patients that I take care of is really thinking of when statins are still truly indicated. And it's tricky because these recommendations have certainly evolved over time. So the most recent one is from AMDA. And from their review and their recommendation, they don't routinely prescribe lipid lowering medication in patients that we know have a limited life expectancy. And we also know that in our elderly, where we do kind of the tightest control with their lipids, they also tend to have highest mortality, even after we adjust for all of the other risk factors that may be contributing. And just in general, there's a less favorable risk to benefit ratio, particularly in patients over 85. And I'm sure many of you may be aware of choosingwisely.org. It's an ABIM directed website that I think is incredibly helpful to help us figure out when certain things may or may not be indicated for our patients. So their recommendation for cholesterol medications in those over 75 is that you should consider deprescribing, because in older patients, they may not live long enough to actually get the benefit that's necessary for a statin to be considered effective. But in those patients who have had a heart attack or a stroke, it is entirely reasonable to continue the statin. So in your patients that are having weight loss, in your elderly patients that are having weight loss or are having a lot of myalgias, I often find this as a really helpful time to think about perhaps deprescribing or lowering the dose of statins. And in general, I feel like I haven't found a ton of resistance from patients when I say I'd like to reduce the number of medications that you're taking. But a lot of times, statins is probably the trickiest conversation. So part of it is also identifying, what's important to your patient and how can you kind of meet them in the middle. So as I mentioned earlier, there's no way we can go through all of the medications, but I really want to leave you all with some resources that are incredibly helpful, I think, in helping to deprescribe. So we're going to talk through deprescribing.org, the start and stop criteria, aging brain care, which is specifically for anticholinergic burden. What we won't be discussing is the Beers criteria. This is an easily accessible list of potentially inappropriate medications for older adults. But what this does not have is any added clinical background or considerations to make while making those changes. So the reason my preferred resources are the first 3 is because I do find that they're a little bit more comprehensive and are just a little bit more thorough, including also having some resources for patients for some of them. So starting with the first one, deprescribing.org. This is from a research institute from our lovely neighbors up north. And they have a similar definition for deprescribing from the one that we talked about earlier, where it's a planned process. What I really like is that they say deprescribing is a part of good prescribing. So backing off when doses are too high or stopping these medications that are no longer needed. So on their website, they actually have a number of algorithms to help you figure out how to taper down on medications. But what I really appreciate about these algorithms is that it kind of talks you through how do you evaluate if the medication is still indicated? How do you have the conversation with the patient? You can, they have some additional resources that you can give to the patients and then information on how to actually do the taper. So last time I checked, their website had algorithms for PPIs, antihyperglycemics, antipsychotics, benzos, and cholinesterase inhibitors. So I just want to show you an example. This is the benzodiazepine one. So starting at the very top, I know this is a little bit busy, but I just want to show some of the key points. So looking at the indication for why the patient is taking a benzodiazepine, and then whether it is something that you would consider continuing, or would you think about deprescribing for this? And it tells you the tapering, how often you'll be monitoring them, and if their symptoms come back, what is it that you do? So I think it's really important when we talk to our patients about deprescribing and they're worried about certain symptoms that are potentially going to come back, that we're also telling them, we're not going to stop treating those symptoms. It's that we're probably just going to change how it is that we treat those symptoms. So the rest of this benzodiazepine deprescribing algorithm gives you the information for how do we engage our patients and caregivers. What are the other things? So the behavioral management piece, what are the other things that we can offer them? And it kind of gives us the good sleep hygiene bit and then talking about CBT resources. The other thing that I absolutely love and I probably use the most is on deprescribing.org. They have a long handout, I want to say. It's probably about 15 to 16 pages. I have saved page 11 of that PDF on my Teams actually, so that whenever I need to use the resource, I can pull it up and download it. This is the benzodiazepine tapering schedule. And visually, I think this really helps patients to see what their medications, how you're going to taper them down and off. And I have them do little check marks to help them remember. And they can even take notes on the days that they took the lower dosages, kind of monitoring their symptoms that they had that week. So the next example, what I just wanted to briefly show you is the cholinesterase inhibitor and memantine deprescribing algorithm. So there are definitely scenarios in which you want to continue these medications. So I like that it takes you through that. It's not just saying, absolutely, you need to stop this medication. But then again, how do you taper down and slow? And it gives you very explicit criteria that you need to think about whether or not you can consider deprescribing. So just showing this as an example. They do also both for iPhones and for Android phones, they do have this I Am Medical Guidelines app for deprescribing.org that you can have on your phone. I also tend to just use it on the website because it's pretty easy to print out some of the information and use. And I think these are also really great resources for us to be able to use for our trainees and to teach them how to think about deprescribing, because I feel like so much of what we learned in medical school was what are the medicines that we are going to be prescribing, and probably weren't taught as much about stopping these medications. So really kind of putting it on the radar of our younger trainees to start thinking about deprescribing just as much as we think about prescribing. So the most comprehensive of all of these lists are the start and stop criteria. So what I really like about this guideline is it thinks not just about medications that we need to stop when they're inappropriate, but thinking about medications that if we needed to treat, what are the right ones to start with, right? And so the stop criteria has guidelines for what we think about in terms of what medications we want to stop. So similar to what we've talked about before, things that don't have an indication, or if a drug was prescribed for a recommended duration and then that it is just indefinitely continued where it was not meant to be. My favorite example, PPIs that are prescribed when a patient is hospitalized kind of get indefinitely continued. So again, reevaluating if there's still a need. And then oftentimes duplicate drug classes. So if they're on two different types of NSAIDs, for example, thinking of deprescribing. And just to give you a sense, so the stop criteria, I keep a printed copy. It's about 10 pages long because I really find it to be a very helpful reference. So each of these are divided into systems. It's a system-based document that goes through which medications are considered more alarming for patients and when we would need to stop. But it's not just saying stop beta blockers, for example, right? It's saying beta blockers in combination with certain calcium channel blockers increases the risk of heart block. Beta blockers with bradycardia or type 2 heart block, you have this risk of complete heart block. So just enough information without it being overwhelming, that is easy enough to use as a quick reference. So then we have the start criteria, which I'm not going to go through and read this to you, but we certainly don't want to omit medications that are optimal for our patients when there is a valid reason. So in contrast for the cardiovascular system that I've put here, so the first one shows, for example, that DOACs are reasonable to use in our patients, even though those that are falls risk and patients with chronic AFib. So I think oftentimes if we are hesitating or pausing on medications and are unsure if they are safe, this is also a really good resource to help us kind of look and see, is this considered a reasonable medication to potentially start? So though it's a great tool, it's certainly not an exhaustive list and it has its limitations. There's definitely room for interpretations because it is not explicitly stated for every single drug. This definitely requires a clinical professional to really evaluate the risks and benefits. And we know there are so many nuances for our patients based on the context of the rest of their health conditions, their other comorbidities. So it is not a black and white sort of thing at all. There's a lot of gray zone in medicine. And so it really is kind of thinking through whether or not it's the appropriate time to potentially take off that medication. There's less guidance in this document about how to actually taper off of specific medications or thinking about what the maximum dosage in a older patient may be, because that oftentimes can vary in terms of medications that we're giving those who have, as we get older, our bodies naturally process medications differently, can hold on to medications for longer periods of time, such as some of the anti-hyperglycemics that were listed earlier. So it doesn't really give us that information in this document. And then the other big thing is we may have limited access to history of prior medications that the patient has tried. And I will say a lot of times I have new patients that are in their 90s that are coming to establish with me. And quite frankly, we may not always have time to go through the entire list of medications that they have previously tried. So this last resource that I wanted to share with you is called Aging Brain Care. And this is primarily for looking at anticholinergic burden for our patients. And I learned about this not that long ago. One of my patients actually came in with this page printed out from her psychiatrist, I believe, that she was seeing. And they had gone through and circled all of the medications that she is on in terms of her anticholinergic burden. And we had both newly started taking care of this patient, and she came in and said, "Hey, I didn't realize that these medicines were all problematic and potentially contributing to some of the symptoms that I have. How can I start coming off of these medicines?" Right? And so that's the easiest case scenario when a patient is coming in and saying, let's deprescribe. But what I like about this burden scale is that it kind of divides up even in category of anticholinergic, which ones have higher anticholinergic burden versus lower. And then I think the biggest thing that I have found to be the most helpful to share with our patients in terms of why we want to decrease anticholinergic burden is all of this data that is pointing to the significantly increased risk of cognitive decline from being on anticholinergic medications for a long period of time. And this was initially done by the folks at the Indiana University Center for Aging Research. There are some folks who have actually developed an online calculator for this as well, where you can just go in and plug in the list of medications that you are concerned have anticholinergic burden, and they can help to identify which medications you can potentially start by decreasing. So when in doubt and you don't have all of the medications for the patient, or even our patients can be unsure because they've got so many medicines and it's really hard to keep track of which ones they're taking, or potentially they have a caregiver who's having these challenges, really calling the pharmacy to find out fill dates, if they've been getting it consistently, if you have a prior prescriber to help round out your history, and really depending on our caregivers to give us more information as well. And I find this to be a really fun lesson for our trainees to try and do. If you have students working with you, I think it's just an excellent learning tool to kind of show how many ways in which our prescribing can go wrong in terms of whether or not the patient really understood why we're prescribing it, have they been taking it, a lot of times, remembering the indication incorrectly, even though they do remember indications for medicines that they need. So it takes a lot of extra work and a lot of time, which we don't always, or not even always, never have the luxury of in primary care. But certainly this is really helpful when you have the time. So I know I've shared a ton of information and a ton of resources. So thank you guys for listening to all of that. And I guess I will open it up to the questions now.
Great. Thank you so much, Dr. Patel. We have some questions, and please feel free to put more into the Q&A for our speaker. Thanks so much for sharing particularly resources that we can go to. So when this comes up, we have some new tools to work with. I know I learned a lot there today. You spoke to this some, but perhaps I'll just ask again, do you find in many circumstances that you as the physician are more often initiating efforts to deprescribe, or does this tend to be more driven by patients and caregivers? And maybe sort of communication tips that you found useful coming from both of those perspectives?
Yeah, that's a great question. So I definitely would say it is more driven by me than it is by patients, even initiating the conversation to deprescribe. So the main kind of points that I typically make with patients is to say, hey, I know you're on a lot of medications. I think that we can maybe make this easier for you and take away medicines that perhaps you're not really benefiting from. And by and large, people are all for it. They're like, yes, less medicines. They're even more excited when they're like, oh, that's my medicine that costs me $30 a month. And I think oftentimes when a caregiver is involved who is potentially managing the medications, they often will agree and say, yes, this is like too much medication burden. And I think if you take the time to explain why that medication is potentially no longer necessary for the patient, that tends to be really helpful in patients being willing to deprescribe. I certainly have had a handful of patients that come in and say, I'm on too many medications. Can you help me figure out what is it that I really need to be taking? But by and large, it's a conversation driven by me.
Great, thanks so much. I'm just reading a comment here online. Thank you for the presentation. Any comments on anticoagulation and deprescribing specifically?
So that has evolved a ton in terms of anticoagulation. And I think it still varies, and there's probably different schools of thought on that. So in general, I think when the DOACs first came out, we weren't entirely sure if we should still be prescribing those, especially for our high like falls risk patients, because obviously there's always the worry of bleeding. And a lot of times we would stop medications like warfarin or aspirin in those patients. But as time has gone on and we've seen the benefits of these medications, some of the most recent guidelines in our older patients is actually that it's safe to continue those medications, especially if you're looking at it from a quality of life perspective. So if they're on it because they have atrial fibrillation and you're trying to prevent a stroke, it tends to be much more beneficial rather than actually deprescribing that medication. So that's one that we would actually continue.
Great, thanks so much. Little bit of a side question here, but related, particularly as you call out just the vast number of medications many of our patients are on and some of the confusion in getting them all right. Have you taken much initiative or have any resources to recommend about things like bubble packaging or sort of pharmacy strategies to help organize medications for our patients?
Yeah, so I've tried doing bubble packaging for patients to make it simpler for their day-to-day, because then it's also easy to remember whether or not they've taken pills for that day. What I have found is for a lot of patients who have joint pains, it is really hard to actually push the medications out of the bubble packaging. So I tend to find that pill boxes are the best. It is just the easiest way to remember. And I try to involve caregivers or their adult children if they're going to visit their mom or dad once a week. I just say, hey, maybe take a peek at the pill box and see if, all the days are done, or if they go in to help every week to fill the pill box, just to get a sense of how many days of the week are they remembering or forgetting. And I do have some patients where I will set alarms on their phone. They're like, I have this phone, but I don't know how to do it. and I'll label the alarm like, take this medication for their medicines that need to be timed and aren't as simple as like morning or night medications. And so that's kind of the other thing to help them remember to take it. But I find those work a little bit better. From the pharmacy perspective, I find what's most helpful is if I have them, oftentimes they can just fax a record of when the prescriptions were filled. And that's helpful for me to see if it was continuous or they were missing filling prescriptions.
Great, thank you so much. Another specific question here in our chat. Many older patients seem to be taking trazodone, for example, 50 milligrams as a sleep aid. Do you try to take them off of that typically?
I try to lower the dosage of the medication, and then ultimately we'll probably bargain with them to try to go a night or two without it and then report back to me how they did. Of all of the sleep aids, I tend to try and help patients say, like, let's try melatonin instead. And I think a lot of times what patients don't know is to get more benefit, they need to take melatonin 1 to 2 hours before they go to bed for it to be effective. And so what I do is when they're on something like trazodone, have them start by just going down to half of that tablet. So go to 25 milligrams. And I let them do it for a couple weeks and say, let's plan to have you do this and to have you come back in a couple weeks or call and let me know how you're doing on the lower dosages. And then depending on, how much their sleep is affected, trying to come up with, okay, what else can we do to help with your sleep? Try to think about sleep hygiene a little bit more. Do a little bit more teaching on how our sleep does change as we get older. And to see if they're not willing to come off, to get them on the lowest possible effective dose.
Great, thank you. And do you have a specific dose that you recommend for melatonin?
Typically 1 to 3 milligrams. I think we're finding that the lower doses tend to work the best. So I always start with 1 milligram, have them take it a couple hours before bed. And again, do the same, like if you've gone a few nights and you feel like it's not sufficient, add another milligram on. And do that again for a few nights to help them kind of find the right dose. I try to keep it 5 milligrams and under in general, but there's no harm in doing 10. It's just most people get benefit by 5 milligrams.
Great, thank you. A useful comment from one of our PMG providers here noting that salad packing in pouches, for example, from PillPack or Simple Meds, is easier to open and a bit simpler to manage for those who may want to stick with the bubble package concept.
Yeah, I didn't know that was a thing. That's great. Thank you. You said PillPack?
Yeah,
the PillPack pharmacy does it?
And Simple Meds, and I'll publish that in our Q&A here. We are fortunate to have really great support from clinical pharmacists in many of our clinic. And I know
that's awesome.
They've helped us out with that concept.
Yeah, that's great.
Well, I have reached the end of our posted questions. Thank you so much for your time with us, Dr. Patel. Feel free to leave us with any parting thoughts. Otherwise, we'll say thank you.
My only parting thought is look at your patient list today, pick one person, and potentially think about deprescribing.
Perfect. Thank you. We'll see you all next week.